On this episode of the podcast, we talk about how we differentiate low back and hip pain.
The Ask Mike Reinold Show. Helping people feel better, move better, and perform better.
Before we get to the podcast, I wanted to make sure you knew about my free online course on the Introduction to Performance Therapy and Training. If you want to learn how to get started optimizing and enhancing performance, this is the course for you. Head to mikereinold.com/performance to sign up today. Welcome back, everybody, to the latest episode of the Ask Mike Reinold Show. I am here with the crew at Champion PT and Performance up in Boston, answering your questions. Anything you want to talk about, we're going to do some combinations of answering questions still, some recent journal article reviews. I think we've gotten some really good feedback on that. So we're going to keep going with that if that's okay with you. And, keep rocking and rolling. So let's see. Who do we have today? We have Anthony Vedetto, Brendan Gates, Kevin Coughlin, Dan Pope, Lenny McCreena. Lenny, who do we have for a loan student today?
We have a one loan student out of our two. He's a fun guy, great guy to get to know. Francesco Casali. I say your name right there, Francesco Casali. I'm going to guess from Mercy University in New York City or New York.
Nice. Have we had a student from Mercy before, Len? Is this our first?
I don't think so. Mercy.
Wow. All right. Good. All right, Cheska, what do we got for a question today?
All right, so we got Tim from Montreal. I'm a recent grad, a little over a year out. And some of my younger athletes, I have had a hard time with lumbopelvic injuries. How do you differentiate between mechanical low back pain and hip-related pathology in athletes?
Good question, Tim from Montreal. Wow. You think this is like Tim Horton, Tim? Like the Tim Horton?
Could be.
I didn't even click until I said Tim from Montreal, but good question. I feel like, Cheska, we talked about this last week kind of in the clinic a little bit with Emmett, right? A little bit about hip and low back pain, especially when you have younger athletes. I think that's what I really liked about this question here, was that, it's about younger athletes, right? So having a hard time with lumbopelvic, how do you differentiate between mechanical low back pain, hip-related pathology? Who wants to start? I'm going to pick Dan Pope, but I want to hear from Kevin Coughlin. I know he's jumping in on this one, but Dan, what do you got?
Yeah, I think the two can be very much related, right? They're so close to one another. And I think a lot of times do present together. I think the subjective is going to drive things for the most part. And generally speaking, when folks have low back pain, it's closer to their low back, right? And if they are having symptoms that kind of extend to the hip, it's usually the back side of the hip and then sometimes the leg if you're dealing with more radicular symptoms. I think for the hip, you're most often seeing anterior hip pain and you're seeing kind of a C sign. So I think those are the big ones. I think you can also just think about that mechanism of injury. So essentially, how did that person hurt themselves? It seems like they just put more strain on the low back. Then you might be thinking a little more low back. If it's more strain on the hip, it could be more of a hip injury. I think the mechanisms are often similar, and it really depends on the athlete that you're dealing with. I think the other one that's a pretty good dead giveaway is just when you're doing your special tests. And I think it's a little tough. You have to keep in mind when you're doing your hip special testing, when you take the hip joint to its end range, you're oftentimes moving the spine. So if I'm just taking that person to end range flexion, I'm flexing the spine. So you have to be a little bit cautious with that. But if I'm doing like a Faber and a Fadier, and I'm noticing I'm getting more anterior pain, right? Reproducing the patient's familiar symptoms, I'm automatically thinking it's a little bit more hip related. And if I am getting more pain in the spine, in the backside, the back of the hip, I'm starting to think it's a little bit more spine related. But I mean, the two could be presenting pretty similarly, or they have injuries in two different areas, two areas going on at the same time.
Yeah, which probably isn't unrealistic, right? I mean, it's, he said young athlete again too. So it's probably like a sport related injury. It's chicken or the egg maybe sometimes, like, was he starting to kind of, get tight or hurt his hip and then he put some extra stress on his back or, vice versa, that type of thing. But man, you made a lot of really good points there, Dan. I think one that I really liked, I thought was cool is while you were saying it, I was thinking of it myself, but you're right. Like, a lot of times, like, groin pain, hip pain, back pain, they can be kind of fumbled together into like one big cluster. But I really like what you said right there. I can't recall the last time I've seen somebody with just hip pathology have isolated back pain. Right? Have you guys, am I off on that? I haven't felt like that.
It's rare. Very
Yeah.
rare.
So, I think that's probably like the first big thing to look for. And I like how you said seaside and to kind of go lateral for the hip because I think that's pretty common too. But yeah, I thought that was really helpful stuff, Dan. It was awesome. Kevin, what do you think? I know you got some good thoughts on this too. I wanted to hear your thoughts.
Yeah, I definitely agree with a lot of what Dan said. And I think just specific to the question, if he's talking about younger athletes, that's where it would start with the subjective for me and getting a good history, because we know there are certain injuries that are common in certain sports. So if you have a young athlete who does an extension rotation sport like baseball or golf or something along those lines, and they're complaining of kind of that back pain, maybe some hip tightness is something you'll see with that. But you immediately want to kind of shift towards start looking at a spondy or pain, primarily coming from the back, versus if this is a, catcher or someone who does a different type of sport, maybe a soccer player, you might be thinking a little bit different. Maybe this is more of a hip pathology. So I think always using the subjective to guide your testing and figuring out what pathology we might be suspecting. I definitely agree with what you guys said in terms of we don't really see pain work its way proximal. So we won't really see isolated back pain with someone with a primary complaint of hip pain. But I guess if we're going through the subjective and figuring out what sport they play, when did their pain start, what's aggravating for them, we start to piece together, does this seem a little more, related to motions of the back or motions of the hip? And I would say also keeping in mind a few big buckets of pain. So maybe spine related pain, which would be something like a spondy, versus radicular type pain, which we might be worried about a little bit of nerve involvement or a disc pathology that we could also see in that population. And then for the hip, I think we're thinking of either intra-articular. So is this someone with symptoms of, FAI or hip dysplasia or something along those lines? Or does this seem extra-articular, maybe more of like a groin-related adductor pain, or even like a high hamstring type pain? So I know that's a lot of buckets, but you kind of get a little lens into what's going on through the subjective. And then when you're taking them through your assessment, I think when we're moving the spine around, if it's reproducing their pain, it's giving us a pretty good indication this might be coming from their spine. Whereas with the hip, right, it's doing tests like Dan said, the Fader, the Faber, not the most specific test, but maybe they're giving us an idea, is the hip joint irritated? And I think with those, important to keep in mind is just that we probably get a lot of false positives on that. So people get some pain, but we don't know exactly like, hey, is this your primary complaint? So always coming back to that primary complaint too, that you're picking up in the subjective.
Awesome. Yeah.
Which
Dan,
which gives me that was
sorry.
me. I don't know if you saw her hand,
Oh,
but
I thought Dan wanted to
my
jump
I got
bad.
in.
one
Kevin,
too.
that's
Oh,
all right.
Dan,
No worries. Yeah.
jump in, Dan. Continue. Sorry, because I
I
had a
figured
case yesterday of
Len's
all
about to
this.
drop like a bomb on us, so
No,
like I
no, no, no,
figured
no.
if you
I'm,
got a
I'm,
comment on Kevin's stuff, Dan, jump in.
I, yeah, go ahead, Dan. I got to wrap it up with my case from yesterday, so it all ties it in.
Yeah, I was just gonna say I'm thinking like one in my head where I had a patient, pretty interesting, but came in and he had terrible anterior hip pain, and he went to a hip specialist and they did find a hip labral tear, and he was thinking about undergoing surgery, and it was very clear that he had radicular low back pain, and I think if that's the case, you're probably going to see dermatomal, myotomal issues, positive straight leg raise, positive slump. Those generally aren't going to be positive in folks that have hip pathology. So I think if you do have radiating pain from the back, like radicular low back pain, I think it's usually pretty obvious if you just do your other tests and try to provoke the spine without provoking like the hip and vice versa. So
Yeah, that's perfect. Len, this is
Right.
starting to sound like a chasing scratch episode, right? I mean, I feel like we're
Trust me,
talking.
trust me. I was
So
just thinking that myself.
kudos to
Um,
Eli, but go ahead, Miller.
yeah, I was telling you at the time. That's hilarious. But no, I had a case yesterday of a woman. Actually, Dan, you're seeing her next week. Not to reveal too much, but anterior hip pain. In her subjective, it was kind of all over the place. Her gait started to change. Like she was really affected by this. very active 40-something-year-old woman. And I'm like, well, I can't rule out your back. I can't rule out other stuff. Like, is it a glute tendinopathy? Because she's getting a little stuff down lateral side, but nothing really. I looked at her back. I had her flex extend. I had her do slump. I had her do all these tests, and it all came back to hip, that anterior hip pain. She had a positive fader and a positive faber. And that was her pain, which is what Kevin says. So I want to tie it into, is that your pain going to be the key question? And then look on the other side too, because you could provoke somebody with all these moves and they think that's their issue. But if you go on the other side, that's also painful. So provoke it on the other side. And I wasn't able to provoke it on her other side. So I think it was pretty clear that she had some anterior hip pain that was probably a result of an FAI, and she had an MRI that showed that she had a pincer lesion and a superior labral tear. So she was getting multiple opinions from PTs, and it's coming to see us now, and hopefully we can guide her in a good direction and give her some closure to the issue. So yeah, I just want to tie it all together, that it can be differentiated.
I remember too, I mean, lots of people have labral tears, right? Especially some
exactly.
athletes, a hockey player or something like that, an ice hockey player.
They're going to find something.
Of course. Yeah. I mean, that's kind of part of it. Then you start chasing the wrong path a little bit here. But, I think I'll summarize it as this, Tim. Clearly you can see even just from our dialogue here that it's not always straightforward. There's a bit of overlap. So that's probably why you feel like you're having some difficulty with this sometimes. It actually makes sense. We do too sometimes. Right. But to kind of tie it up, what we talked about the students with Cheska and Emmett last week a little bit here is, the concept of structural and functional diagnoses and your exam process and going through that, right? Just keep in mind that oftentimes they're confusing because you'll have one area that has structural pathology and the other area has several functional pathologies that are probably leading into that somehow, and vice versa with the hip and the back. So kind of keep that in mind. You almost treat them together, quite often. So keep that in mind. That might be why sometimes you're getting, I don't know. I guess you're a little unsure of yourself sometimes because they might be having mechanical low back pain, but they're having some functional limitations of their hip, and who knows if it goes together. So great question, Tim. Appreciate that. If you have any questions, just head to mikereinold.com, click on that podcast link, and you can ask away. And please, Apple Podcast, Spotify, some new AI generated podcasting that's not invented yet. If you follow us there, like us, subscribe, review, we appreciate it. We'll see you on the next episode.